morning, sir.
Good morning.
Hi everyone.
Sir, good morning, sir.
Yeah, am I audible?
Yes, sir.
Yeah, good. Just a minute. Okay. So I think it's time to start. We have around 11 people and more are joining. So let's start. So I would like to talk to you about brainstem tumors, which is an important topic, and surgically also it's quite challenging. So for the surgeon as well as the resident, it's pretty important to understand that how a brainstem tumor behaves and when to operate, and whether all need operation, and if operation, which approach to take, then and what are the safe entry zones to reach into that uneventfully. So it's a huge topic, so we will have to divide it into parts. So we will start with surgical anatomy and the brainstem glioma classification sort of thing, and then go to the safe entry zones later on. So I'm just sharing the screen. Just be here for the time being. Can you see it?
Yes, sir.
You can visualize my screen?
Yes, sir.
Yes.
Yes, sir.
So
Yes, sir.
let's come to the basic anatomy. As you all know that brainstem comprise of the midbrain, pons and the medulla, and it's a very complex structure, both functionally as well as anatomically. Various nuclei right from the cranial nerves 3 to 12 are housed in the brainstem, and of course reticular formation in the midbrain all plays a big role in maintenance of consciousness and homeostasis of the body. Historically, it has been always difficult to reach the brainstem because of the deficit which will ensue following its following surgery on brainstem. So many of the people on brainstem tumor was supposed to be the death sentence, and nobody used to touch them before. So it was empirically managed with radiation and chemotherapy, and nobody used to touch brainstem tumor in the 1950s. So as these are some historical sentences which are worth mentioning by the greatest of neurosurgeons, that Bailey said that brainstem glioma were a hopeless problem for treatment. Dandy said in 1962 there was little indication for attempting any enucleation of the tumor in the brainstem. even Baker published a series of just a few cases of subependymal gliomas. And then came in this late 1960s, one of the first series or by Poole, which operated brainstem glioma, some of them having a long-term survival. But however, in the 70s and with Yasser Gill's microneurosurgery advances, there were many advances. There were advances even in the imaging part of thing. So the CT came in, the MRI came in the 90s, and then there was also attempt to subcategorize the tumor of the brainstem into various low grade and a content sort of tumor, which can be operated, which can offer a better prognosis. So from then there are various series on the brainstem gliomas by Bricolo and Heros. Many series have come after that. So gross anatomy, as you all know, this is the skull base. If you are seeing from below, this is the base of the skull, and the brainstem will look like something like this. So this is the pons, and the midbrain lies above that, and this is the medulla, the pyramids, the olive, and the various cranial nerves take their origin from each of this area. So from for the beginners, the third and fourth cranial nerves arise from the midbrain. The 5th to 8th arises from the pons, and 9th to 12th arise from the medulla. And there is specific place from which they arise. So we should know anatomically whenever we are going on a surgery on brainstem that where these cranial nerves lie and where their nuclei lie, because if you damage that, then there will be permanent cranial nerve deficit. So as you can see here, this is the midline sulcus. These are the pyramid. Between the pyramid and the olive, the 12th cranial nerves come out, and behind the olive, so comes the 9th, 10th, and 11th. So you should all know this anatomy. Then this 7th nerve and the nervus intermedius, where it arises from the pontomedullary sulcus. We are only akin to seeing the 7th nerve in the CP angle, where it arises from near the foramen of Lashka. But if we never approach brainstem in this way to know exactly from where the cranial nerves arise. So you should clearly know what is the origin. And all these cranial nerves arise from the front aspect of the brainstem except one cranial nerve. Dr. Shaurya, can you tell me which is that cranial nerve which arises from the dorsal aspect of the brainstem?
Fourth nerve.
Okay, anyone? Mukesh?
Fourth cranial, fourth.
Fourth, yes. The
Appropriate.
cranial nerves arise from the dorsal aspect of the brainstem. So this is a more more magnified view of what I am telling you. So this is the third nerve which is arising from the interpeduncular fossa. The fourth nerves come from the back side. Then this is the trigeminal nerve. This is the sixth nerve, abducens nerve, which arises from the pontomedullary sulcus quite medially. And the seventh nerve arises laterally from the pontomedullary sulcus, as well as the vestibulocochlear nerve arises along with the seventh nerve. Then, as we told you, the glossopharyngeal nerve, vagus, and the 11th nerve arises from here, and the between the pyramid and the olive arise the hypoglossal nerve. So this continues as the anterior median sulcus of the spinal cord below, and at this level there is the pyramidal decussation. So lower part of medulla, there is pyramidal decussation. So the corticospinal tracts cross here. Similarly, this is the gross anatomy specimen, and here you can see again what are these structures. Can anybody tell?
Mammillary body, sir.
Follicular.
Yes, mammillary bodies. You see, when we do a third ventriculostomy, you actually do a fenestration here. These are the mammillary bodies. This is the infundibular recess and the optic chiasm, and this is what we see in endoscopy when doing a third ventriculostomy. So you are reaching here in front of the mammillary bodies. Then as you come, the interpeduncular fossa, the third cranial nerve taking origin. Then this is the pons. This, as we see, this is the 7th, 8th nerve complex, most likely. Then this is the 5th nerve, median sulcus, and what we told about the lower cranial nerves is arising from down. Okay, so this is the ventral aspect of the brainstem, which you should know. And the corticospinal tract are placed anteriorly. So if you see the anterior section, cross section of the brainstem, the corticospinal tracts are always placed to the anterior aspect of the brainstem. And then we come to the then this is the specimen which you will see in vivo with all the and everything. So this is the basilar artery formed by the junction of the two vertebral arteries at the pontomedullary sulcus. So medulla you can see clearly, but the pons will be obstructed by the basilar artery in the middle part, and the AIIMS will be the first branch from the basilar, and then the superior cerebellar artery and the PCA and the third nerve in between. You know that anatomy. Then the 8th nerve, the branch you can see is arising from the AIIMS and going along the 8th nerve. That's the labyrinthine artery, which we know goes into the internal auditory meatus when we do a CT angle surgery, and we can see that. And the pica arises from the vertebral artery. So this is the pica. So this is the AIIMS, this is the pica. And the pica is in relation to the lower cranial nerves, and AIIMS is in relation to the 7th and 8th cranial nerve. And the superior cerebellar artery is in relation to the third nerve. So this is the applied anatomy of anything you see has to be known, because you can potentially damage all the structures if you do not know this anatomy. You are seeing only the my screen, or you can also see the participant list and everything?
Yes, sir, that can be seen.
Yeah, that is
Participant list.
okay.
But predominantly your screen is visible.
That's good. Okay. Then coming to the lateral aspect, if we approach the brainstem from the lateral aspect, what will we can see? This is the mid-sagittal section, and as you can see, this is the 4th ventricle. This bulge is of the pons. The midbrain lies above and the medulla lies below. This bulge is of the basis pontis, which forms the bulk of the pons. This is the basilar artery, which we just seen. Then again, this is the bifurcation of the basilar into two PCA. The SCA lies below. This is the third nerve from the lateral aspect. Then this what artery this will be? Ajay, we just seen it in the anterior ventral aspect. Which artery is this? Lower part of pons, arising from the basilar, one of the first branches.
Pica, sir.
Pica.
No, no. That
Pica is
will
lying
be
here. Is labeled. SCA is also labeled. So what is this?
yeah, ICA sir. SC
ICA.
inferior.
Yeah. ICA. ICA is the anterior inferior cerebellar artery. And do you know what does it supply? Anybody, if the ICA is clipped or damaged, what part of brainstem will develop an infarct? Pica, you all know, occlusion of pica causes a lateral medullary syndrome. But what is the infarction of ICA causes? So this is a question for the big boys. Who are the big boys available? Ravi. Is Ravi there? I think he's there.
Cerebellar peduncle, sir.
Cerebellar peduncle?
It's a middle cerebellar peduncle infarct.
I think I want a better answer. That is not the correct answer.
Okay.
Who had just passed or is going to pass? Surya. Surya is there. Surya.
I'm not sure, sir.
I'm not sure. So till the next class, you find out what does it cause. If the
Yes,
SC
sir.
is clipped and the ICA is clipped, we will have that as the first question next time. So
The lateral pontine syndrome.
yeah, ICA causes lateral pontine syndrome, and SCA you will all read and come up. Okay, so what is lateral pontine syndrome? What is lateral and inferior pontine syndrome? So there are many subdivisions. So you should all read. It is given in some of the clinical examination books also. So just read about that. So this is the fourth ventricle, which is at the back of the brainstem, and we are more conversant with this anatomy as we go from the midline suboccipital to lobular approach, open this medullary velum, and see this brainstem in the posterior aspect. So this is usually, and if we go by splitting the vermis, then we reach by reaching here, something like that. So we go through the cerebellum there or by the tilovelar approach. Then what is this? Sandeep Mishra, Sandeep Bora, anybody can volunteer. What is this?
Rectum.
Okay, nobody has the answer.
The superior medullary velum. I'm
No,
not
I'm
sure.
telling about this cavity which is communicating with the fourth ventricle.
Aqueduct. Aqueduct.
Yes, cerebral aqueduct. So it communicates, connects the third with the fourth ventricle. Okay. Then this is what we will see from the lateral aspect, the cranial nerves which we were discussing, and this is what I mean to say, that this is the fifth nerve and the trochlear nerve which goes dorsally, the third nerve comes ventrally, and everything which we discussed in the ventral aspect. Then coming to the more familiar posterior or the dorsal aspect, and the brainstem forms the floor of the fourth ventricle, also called as the rhomboid fossa. The rhomboid fossa doesn't have midbrain, so the upper 2/3 is formed by the pons, and the lower 1/3 is formed by the medulla. And it has the rhomboid fossa has been divided into three parts: superior oblique, the pontine part, the middle or the junctional part, and the inferior. Junctional part has the peduncle and stria medullaris, divides the upper and the lower. Then coming to a more
So
now.
Yeah. I request everyone to mute apart from that.
Yeah, I'll mute.
So no, sir, not you, sir. Rest of them, because there's a lot of disturbance.
Yourself. So when you are asked some question, you can unmute. Okay. So
Yes,
the
better.
convolution is divided by a median sulcus into two equal parts. So this is the median sulcus, and there is another faint sulcus just parallel to the median sulcus, that is called as the sulcus limitans. Okay, so this is the sulcus limitans which divides it's labeled here. Yeah, so this is the sulcus limitans. So it actually divides the rhomboid fossa into two parts. Medial part is called as the median eminence, and the lateral part is called as the vestibular area. And the median eminence has a lot of important things: the facial colliculus, the hypoglossal triangle below, the vagal triangle, and the area prostrema. This is all in the why it is called as the calamus scriptorius. This is the area, and which tumor arises from this area? Anyone? From this area, the calamus scriptorius, which looks like a nip of the pen. That is why it is called as calamus scriptorius. Ependymomas arise from here. So base of the floor of the fourth ventricle near the calamus scriptorius is where the ependymoma arise. And this nip of the pen has the hypoglossal triangle, the vagal triangle, and area prostrema. So whenever you are doing surgery in this region, you should be monitoring the 12th cranial nerve by neuromonitoring. So that will help you know the hypoglossal triangle and save it. Okay. So facial colliculus is here. Facial colliculus is formed by which two cranial nerves? Which cranial nerve nucleus and which cranial nerve? Mukesh, can you tell?
So 6th and 7th.
So cranial nerve nucleus is of which nerve, and the fibers are of which nerve in facial colliculus?
The nucleus of 6th and fibers of 7 wind around it, sir.
Yes. So 6th cranial nerve nucleus and the 7th cranial nerve fibers form this eminence called as the facial colliculus. Okay. So this is a diagrammatic representation of the same thing. Can anybody tell me what are these four dots, big dots?
Superior and inferior
Yes,
colliculus.
superior and inferior colliculus, which are the part of the midbrain, and this forms the quadrigeminal plate. Okay. Then we already seen the fish hypoglossal and okay, where does the MLF lies? Median longitudinal fasciculus. Can anybody know? Tell me where actually the MLF lies in relation to the rhomboid fossa.
Sir, it is mainly periaqueductal region extending from midbrain to the thoracic spinal cord, sir, throughout in the midline.
In midline?
Sir, midline.
Paramedian.
Just para.
How much paramedian? This is also paramedian. This is also paramedian. It is just a small area. So how much paramedian does the MLF lies to the midline sulcus?
5 mm.
Yeah.
5 mm.
Yes, around 5 mm. So you have to be really careful not to do any incision within 5 mm of the midline sulcus. You may damage the MLF. So all the safe entry zones take this into account, that any incision of the brainstem should never be within 5 mm of the midline on either side, or it will risk damaging the MLF. Okay. So brainstem gliomas, approximately 1% of the all tumors, most commonly in children. Median age is around 6.5 years in children, and there is another peak in adults in 3rd to 4th week. There is no gender predisposition. Mostly in 75% of them are diffuse, and 25% only are focal. And most focal tumors occur in midbrain, which is actually the most difficult to access. So those who can be focal tumors can be operated. They are in midbrain, and it is a pretty compact structure with reticular formation, with an difficult to reach, and the outcome therefore it's quite may not be satisfactory always. And pontine tumors are mostly diffuse and high grade. So this red are the high grade tumors, and the blue are the low grade tumors. And as you can see, the pons is mostly occupied by high grade tumors, except some which can be an exophytic sort of thing, which are projecting in the 4th ventricle, which can be a bit on the lower grade. Medulla are usually benign tumors, and the midbrain also are lot of benign tumors and focal tumors. So this is a tectal plate glioma, which are usually benign and a quite indolent course. So we just take a biopsy and do a CSF diversion, and the patient do well for a lot of years. So this is an approximate distribution of high and low grade tumors. So what are the classification system which come for brainstem tumor? There are a lot many. So you will, whenever in exam you will be asked brainstem classification, tumor classification system, you should know this name: Epstein classification, Epstein McLeary. There are a lot many, but of course Epstein classification you should know because it is one of the first. And as we come forward, we'll tell you another classification. So how Epstein divided them based on the CT morphology as an intrinsic. Intrinsic can be a diffuse tumor, a focal tumor, or a cervicomedullary tumor. Then he divided it into exophytic if it is beyond the boundary of the brainstem where it is projecting. So if it is projecting into the CP angle in the anterolaterally or posterolaterally in the 4th ventricle or in the brachium pontis, the middle cerebral peduncle. And one more category was disseminated in that area, in which there were positive cytological finding or a positive myelographic finding, like maybe a drop metastasis sort of thing or a CSF pathway dissemination. So this was his initial classification, which was then changed with MRI advent into diffuse focal cervicomedullary by Epstein and McLeary. Then this is another lot many classification, Barkovich, Stroing, but you may not know all of them by heart. But Epstein, McLeary, and the more recent one, then Albright, Fishbane. So forget all this, then come to the more relevant classification and more recent classification by Morris Chu. Is based on CT and MRI and divide the brainstem tumors into diffuse, intrinsic focal, focal exophytic, and cervicomedullary. So this is a more rational classification because this also guides the treatment. If diffuse, no surgery, intrinsic focal operated, focal exophytic operated, not completely, but the exophytic component has to be operated, and cervicomedullary needs to be operated. So it gives a more rational classification of whatever a surgeon need to know. Then you may or may not be aware, but even our department had proposed a brainstem glioma classification, and it is a 2009 classification in which what they did was they divided into an intrinsic tumor which are well within the brainstem axis without any breach of parenchyma. So it is like a focal intrinsic tumor. Then expanding variety, which was well delineated on MRI, slow progression, good preservation of motor function, and size may or may not be about 2 centimeter. And what is actually meant by that is, as per Chow 2, it actually matches Chow 2 and Chu 4 tumors, like cervicomedullary tumors, and this what we were telling is intrinsic focal and cervicomedullary
And exhibiting.
will match the in our classification the expanding variety. Okay, then there is diffuse infiltrative variety which will match the type 1 of Chu, and this one they categorize separately the ventrally located tumor. So pure ventral location, ventral and dorsal in relation to brainstem at any level is decided uh, mostly by the medial lemniscus. So if it is arising up in front of the medial lemniscus, it is considered ventral, and it is behind the medial lemniscus, it is considered dorsal, because there is fundamental change in the anatomy at this level. So more dorsal has less critical structures, and more ventral you go, so you have lot many cranial non-nuclei, the pyramidal tract and everything. So this was a practical classification. So ventrally located, they didn't advise surgery in 2009 because of the extreme deficit which can be caused by approaching this tumor. However, it has changed by now, and even a focal intrinsic ventrally placed tumor can be approached via the safe entry zones on the ventral aspect. So since it's a departmental classification, you should know this. Actually, it doesn't have much meaning, but more important is to follow the Morris 2000 law. Okay. So can anybody now tell me, don't read from below, what is this tumor? A. Who's there? Ajay.
Tectal glioma, sir.
Tectal plate glioma. That's right. B.
Sir, it should be ependymoma, sir.
No, these are all brainstem glioma. Ependymoma is not a brainstem glioma. It's an intrinsic midbrain tumor. Intrinsic, focal intrinsic. It is within the confines of the brainstem, not coming out of the brainstem, and it's focal. Okay. Then this
Yes, sir.
D is actually an exophytic glioma coming into the fourth ventricle. C is an intrinsic medullary glioma. This E is of diffuse glioma because it's just diffusely infiltrating the brainstem. G is a exophytic medullary glioma, and F is a intrinsic medullary glioma. So you should be conversant with this with these terms like intrinsic, focal intrinsic, diffuse, cervicomedullary, and dorsal exophytic. Okay, so exophytic, it can be dorsally or laterally exophytic. So giving you an example, in this tumor, the pons is completely infiltrated by the tumor. You cannot see normal brainstem anywhere. The basilar artery is symmetrically encased. So this is a diffuse brainstem glioma, Chu type 1. No surgery, just if there is hydrocephalus, do CSF diversion and send the patient for radiation. Okay. Then focal brainstem glioma. This is involving the medulla. A more ventrally placed parenchyma of normal parenchyma is draping this. So it's a focal intrinsic. It's not projecting out. It's just thinning out the brainstem and completely intrinsic. Okay, medullary, focal medullary glioma, Chu type 2. Then type 3 is an exophytic glioma. So part of the tumor is inside the brainstem and part is coming exophytically, dorsally into the fourth ventricle, filling it partially. So this is a dorsal exophytic glioma. What you have to do in these cases is to remove this tumor flush with the fourth ventricular base. So don't enter the brainstem, just up to here, you have to operate. So like this. So if you find it, you can leave a rim of the tumor and remove all this tumor. So that will decreases the patient's hydrocephalus and so focal dorsal exophatic need to be operated till the fourth ventricular floor. Then a cervicomedullary glioma. These are been categorized as CHU type 4, and they actually behave as a cervical intramedullary tumor and go into the medulla and lifts the fourth ventricle. So these actually are benign and have a very good prognosis if they can be completely excised in most of the cases. Okay. Then what is the molecular pathogenesis? As many of the brain tumors have a mutation of the p53 gene, then EGFR amplification, as in any other gliomas, can be seen. Then trisomy 1q, chromosome 19 deletion, there's some of the tumors which can show. If it is associated with NF1, they have a more indolent course. They are less aggressive in an NF case. The brainstem glioma more often benign and focal. How does they look on CT? They look, diffuse lesion look like a hypodense on NCCT that enlarge the pons. That is also called as diffuse pontine hypertrophy and displace the fourth ventricle posteriorly because it is involving the entire brainstem, entire pons. And they have inhomogeneous post-contrast enhancement on CT scan. Focal midbrain tumor tectal plate glioma may or may not be seen on NCCT and CCT, and leading to a false diagnosis of late onset aqueductal stenosis. So you should bear in this mind. So any adult patient who comes to you with aqueductal stenosis, you should always rule out a tectal plate glioma, because on CT it is very difficult to differentiate a tectal plate glioma from the normal midbrain, and you should get an MRI and see if there is a T2 hyperintense change or something in the tectal plate region, which can be suggestive of glioma. So late onset aqueductal stenosis. So if there is aqueductal stenosis in child, that's most likely because of the aqueductal death. But if it is presenting in adults, it is mostly due to a glioma. So this one point you should always bear in mind and get an MRI for all aqueductal stenosis. Then MRI is definitely imaging modality of choice. It shows you the precise localization and surgical approach also, whether it's a focal tumor or an exophatic tumor or a diffuse tumor. And together with the clinical picture, it very often tells you that what grade of tumor it is. So it's a high grade or low grade. The low grade will have a more indolent course, will be focal, where there won't be any breach of the brainstem boundaries, and it will be completely contained. So this can also tell you the prognosis of the patient. So diffuse brainstem glioma, which you will see more often, is hypo on T1, hyper on T2, and hyperintensity can extend into adjacent midbrain or medulla, as you have seen in one of the cases. Contrast enhancement can be seen in only 1/3 cases, and there is the contrast enhancement doesn't signify anything that it's a high grade or low grade, and they are uniformly bad. So even if they do not enhance, they are not low grade. So as you can see, what I was trying to tell you, that this is a pontine tumor, but it is infiltrating a lot of midbrain also. So you should bear in this in mind. This is the characteristic of a diffuse glioma. Then focal glioma are well circumscribed, more often maybe partially cystic also, without edema and infiltration. Midbrain is more common location. Pons are usually diffuse. Medulla and midbrain more commonly are low grade. Then MRI shows again hypo on T1, hyper on T2, and nidus of focal enhancement. Many of them are pilocytic astrocytomas. So midbrain and medullary focal intrinsic tumor usually are pilocytic astrocytomas. Okay. Then dorsally exophatic they resemble as if you are dealing with a intra fourth ventricular tumor like ependymoma, or an astrocytoma which is filling the fourth ventricle with, and they need to be differentiated on a T2 weighted imaging. This contrast will even an ependymoma look like this on contrast with heterogeneous enhancement. However, when you carefully see the T2 sequences, you will definitely see that brainstem is also involved, and it is the brainstem glioma which is coming in the fourth ventricle. So all imaging has to be seen carefully. Then the practical decision, whom to operate, whom not to operate. So if the MRI is the imaging modality of choice, if you feel that it's a diffuse lesion, which is an usually pontine, high-grade, clinically aggressive lesion, there is a short history and multiple cannula involvement, internuclear ophthalmoplegia sort of thing. So there is no need of doing anything for such tumor, no need of biopsy, CSF diversion. Yeah. Anybody wants to add something?
Rahil, please mute your.
So they had to be sent for direct RT and CT after doing a CSF diversion. However, if the lesion is not diffuse on MRI, so regardless of the location, they have a significant probability of being low grade because it's an intrinsic tumor, focal tumor. So they can be low grade. So if you operate, if they are pilocytic has a very good prognosis as far as histopathological aspect is concerned. So you should attempt excision in those cases. So coming to the non-diffuse kind of MRI, if it's a cervicomedullary tumor, they are usually low-grade astrocytomas and gangliogliomas, and radical surgery has to be done. So CHU type 4 has to undergo a radical surgery, and we have done a lot of such cases in which you have to follow the intramedullary, cervical intramedullary tumor surgery, like splitting the midline, doing a myelotome in the midline, and preserving all the normal tissue and removing the tumor, do it under intraoperative monitoring, and they usually can be excised completely. They do not actually infiltrate the medulla; they actually elevate the medulla. So that's a good thing. The cervicomedullary actually behaves like cervical intramedullary tumor. So they just have in the upper part, they elevate, come out of the brainstem and just elevate the medulla a bit. There is hardly any medullary infiltration in such cases. So radical surgery and long-term outcome is good. If it's a tectal plate glioma, ETV plus minus biopsy through the same burr hole. Or can anybody tell me if you have to do an ETV and an ETV plus biopsy of a tectal plate glioma, how your approach changes as far as the surgical planning is concerned? So I'll ask Dr. Surya, tell me.
We, in a sagittal view, we plan the trajectory. The burr hole is more anterior compared to a burr hole.
So how do you plan? So
we draw a line
yeah,
from the.
it's relevant. I'll just MRI. Okay, yeah. So this is the tectal plate. Okay, this is the aqueduct, and you have to draw a line from here to the sorry, I cannot draw it, but I can tell you that this one line will go like this, and the other line of the third ventricular floor will go like this, and you have to make a burr hole in between these two lines. If you want to do an ETV, if you want to do an ETV, your line is just anterior to the coronal suture 1 centimeter, the coccus point. And for this, your trajectory is almost quite anterior to reach here. From this, you cannot reach here. So you have to make a burr somewhere between them. So it comes out around 3 centimeter in front of the coronal suture and usually at the hairline. So this is what is the burr for a combined ETV and biopsy. Despite that, at times, if you feel that it's dangerous to take a biopsy, you should not attempt it. You just do an ETV and come back. These are very indolent tumors and they may not harm in the long term. Okay, you can follow them. Then where were you? Yeah. Then focal medullary. If it's a medulla oblongata focal tumor, up to 50% are low-grade astrocytoma. Surgery may be considered knowing all the risks and benefits. There are safe entry zones to reach the medulla from the dorsal aspect, from the ventral aspect. We'll come it in the next class about how to reach it without damaging. So that is about the focal tumor. Then if it's a cystic tumor, they are again usually a pilocytic astrocytoma. Then focal cystic will be managed same as a focal intrinsic tumor, focal solid tumor, cyst decompression and radical excision of nodule. And then we have the dorsally exophytic. I'm sorry. Dorsal exophytic usually are low-grade astrocytoma. Surgical excision flush with the fourth ventricular floor as we discussed. So majority. So it's like an oncological debulking. You remove the maximum part and leave the rest which is dangerous and follow it up. So to take home message regarding this, they are a brainstem gliomas are a heterogeneous group of neoplasm. There is importance of MRI in diagnosis and planning of treatment. You can minimize the complication by operating upon benign lesions, and that too in the presence of minimal neurological dysfunction. You should have a knowledge of safe entry zones. So since it's a huge topic in itself and you should all know it well, so I have subdivided it into 2 different parts. So we'll come to it in the next part, because there are many safe entry zones now. You can have a safe entry zone from the posterior aspect, from the lateral aspect, as well as from the ventral aspect. So you can approach the brainstem now 360 degrees. So you just should know from where you have to go in. So we'll cover it in the next talk. And diffuse tumors are almost invariably malignant and should not be operated upon. So direct RT and CT. So focal medullary tumors are likely to be benign, and though surgery can be associated with significant morbidity, but still people are attempting it with the knowledge of safe entry zones and with the monitoring available nowadays, with even which we can map each cranial nerve. It is still attempted in a lot of patients nowadays, of course by telling all the risk and if the patient consent to surgery. Dorsally exophytic again are likely to be benign. Radical excision do not enter brainstem, flush with the fourth ventricle and stop there. Cervicomedullary likely to be benign. Radical excision has to be done, like a cervical intramedullary tumor. Cystic tumor, again radical excision. Focal pontine tumor, radical excision if the tumor is close to the surface. So they have to be approached like the focal medullary tumors. By the safe entry zone, there are various safe entry zones, the supra and infrafacial triangle through the fourth ventricle for the pontine region. So this was the first part of the lecture. Are there any question? You can unmute now yourself.
Hello. Hello.
Yeah.
So Dipanshu this side. So I just wanted to ask you one thing. This in between you told that focal midbrain tumor in the tactile gliomas, they particularly don't enhance on the contrast, and the patient present with the late onset aqueductal stenosis. So
Yes.
you might diagnose it late. So is there any precise reason why this particular tumor doesn't take the contrast and the tumors above and down they enhance?
No. It is not that. The tumors below enhance. The enhancement is not related to the prognosis of the tumor. Even the lot of time we see a high grade pontine glioma, diffuse glioma not enhancing at all. So enhancement has nothing to do with it. Sometimes they may not enhance. So what happens is CT, obviously the posterior fossa structures are not seen well in the CT, and there is a subtle change in the contrast, the signal intensity on CT in the just the tectal plate, then you may not pick that on CT. That is why it is important to get a MRI in all such aqueductal stenosis in adult cases, because at times there can be a flare hyperintensity or a T2 hyperintensity, which is suggestive of a midbrain tectal plate.
Tectal plate involvement.
So enhancement has nothing to do with it, and there is no reason why it doesn't enhance and the others enhance. Even the high grade tumors doesn't enhance. So it is nothing to do with it. The problem is enhancement is actually related to the blood flow, and blood flow and the brainstem gliomas are actually classified based on infiltration rather than blood flow. So if they are more infiltrative, they are considered high grade, diffuse sort of thing. If they are contained, so they are considered benign. So it is as per the location that they are subdivided. Okay. So anyone else has any question on this?
Hello. Hello, sir. One question, sir.
Yeah.
Hello.
Yeah.
Sir, regarding the dorsal exophytic tumor, sir. So why don't we enter the brainstem, sir?
Because
Is it because of the entry zone?
no. The problem is it has already infiltrated the brainstem. Dorsal exophytic are not focal tumor. They are actually diffuse tumor which has involved a part of the brainstem and come out. So whatever part has come out of the brainstem is safe. However, whatever part is inside the brainstem, this is infiltrated. You may not be able to see any landmark like facial colliculus and strium medullaris. The very structure you depend your entry zone will be not seen. So how will you do that? And that can actually potentially infiltrate the neural cranial nuclei also. If you attempt excision, you can actually damage them. That is why it is not advisable to enter in a exophytic glioma beyond the fourth one.
Okay, thanks, sir.
Okay, so I will just have a question for you based on this. So, okay, I'll stop share and no, okay. Yeah, I'll stop share so we can all see our. Okay, so you can mute yourself or I'll mute. Everybody can unmute themselves, okay? So we can have some questions. Yeah. So, Dr. Sandeep, yeah.
Yes, sir.
Can you tell me what classification are we using for the brainstem glioma more commonly?
So right now we're using Chow classification, sir.
Chow
Basically,
classification. How they
yes, sir,
divided
based on-
the tumors?
So from grade 1 to grade 4. Grade 4 is dorsal exophytic. Grade 1 is the diffuse.
Number 2 is not dorsal exophytic.
Hello.
Number 1 is diffuse. Number 2?
Number 1 is diffuse, sir. Number 2 is intrinsic. Like 2 and 3 are focal, sir. So basically, sir, it's basically in reverse order, sir. 1 is more severe, and gradually it comes down to be more benign, sir. I'm like depending upon operability, one is inoperable, and gradually like it's intrinsic
That's
focal,
right,
then
but
exophytic focal, and then cervicomedullary, sir. Grade 4 is cervicomedullary.
4 is
So it's more
cervicomedullary.
and more operable. Yes, sir.
That's right. Number 1 is diffuse, number 2 is focal intrinsic, number 3 is dorsal exophytic, number 4 is cervicomedullary. So this is a classification which we will follow. Then we should also know the AIIMS classification, and you should read that A1, A2, A3, ventral, ventral location, all these things. Then you should be conversant with the anatomy of the brainstem. So before the next class, which we will be having next time, you should revise this initial anatomy landmarks on anterior as well as the lateral aspect as well as the posterior. Okay. So
Yes.
what is the quadrigeminal plate? Mukesh, can you tell me what is quadrigeminal plate?
Both those colliculi, superior and inferior colliculi, together they are called the quadrigeminal plates.
Yes, the superior and inferior colliculi are called the quadrigeminal plate. So what will happen if we do a transaction between these colliculi? You know?
The fourth nerve can get damaged, sir. Trochlear can get damaged, sir, because it arises in between.
More relevant than just fourth nerve. If there is an intercorticular transaction, what happens to the consciousness of the patient?
So damage the reticular activity.
Is in
RS.
Yeah,
patient will
Mukesh
be
is on the right track.
patient will be in M3 status. मतलब he will be in oppositotonous posturing if there is a transition between colliculus.
So I'll ask all of you to go back and learn and tell me next time. There are two questions. Yeah. What is the anatomical basis of decorticate and decerebrate posturing, and why it happens? So next time when you come back, any of you who will volunteer to read about this, Mukesh, you will read about this decorticate
Yes,
and
sir.
decerebrate, and
Yes, sir.
the Pontine syndromes or the SCA, ICA, and PICA syndromes will be covered by Surya. So that's
Yes.
sort of. So you should all know what will happen at what stage of brainstem. Then
Yes.
Dr. Dipanshu, what will happen if MLF is damaged?
So MLF is damaged.
1.5.
So they are
1.5.
this posterior column surface everything.
What is happen? What is the what is that?
INO, sir. INO.
1.5 syndrome.
Lateral MLF.
No, 1.5 syndrome is different. I am just asking MLF.
It's INO, sir. INO. This INO will happen. Internuclear ophthalmoplegia. Internuclear ophthalmoplegia, sir. Like there'll be basically disconnection between the two eyes. Like one will, if you are affecting.
While in the medial.
Dipanshu, please tell me. Then we will come to the next person. Dipanshu, you have to read.
Yes, sir.
INO is an important topic, and you should know how an INO presents. So you will be telling us about INO. Okay.
Yes, sir.
So INO exactly क्या होता है? Means in the sense कि कौन सा कहाँ जाता है, कहाँ nystagmus होता है, किसमें adaptation failure होता है, किसमें abnormal होता है, जो भी है, whatever it is, you have to tell me. Okay. Then come to the rhomboid fossa anatomy. Can anybody summarize? Sarvesh is which year?
Sir, I'm second year JR, third sem JR.
Second year JR. Okay. Okay. Tell me, Sarvesh, which all cranial nerves arise from the medulla?
Sir, 9, 10, 11, 12 arise from medulla. 12 arise from the sulcus between pyramid and olive, and 9, 10, 11 arise from the posterolateral sulcus of the medulla.
Yes, you're right. So, good. So, anybody Guria, Mukesh, Rahil. Rahil, yes. Are you there, Rahil?
Yes, sir. I'm here, sir.
Yeah. Can you tell me briefly the dorsal aspect of brainstem? What all structures lies and the rhomboid fossa anatomy?
Sir, mm, from superior to inferior, from post dorsally we have in midbrain we have superior colliculus followed by inferior colliculus,
No.
and then
Rhomboid fossa. Midbrain is not a part of rhomboid fossa. Rhomboid fossa is the fourth ventricular floor.
yes, sir. Sir, we have a midline, sir, sulcus.
Yes.
Sir, then there are two lateral, two paramedian sulci also, sir.
Paramedian or a sulcus limitus. It is called as sulcus limitus.
Yes, sir.
So,
And then there is a horizontal line which divides the floor of the fourth ventricle into superior half and the inferior half. Hello?
that is called a junctional part or intermediate part, and have stria medullaris
Yes,
on either side. And below, the lower half has what all structures, and the upper half has what all structures.
Sir, upper half has facial colliculus along with the sixth nerve nucleus around which the facial colliculus rotates. Facial nerve rotates.
Yes.
Hello.
And MLF lies within 5 mm of the midline. Lower half has the
Yes, sir.
vagal triangle, the hypoglossal triangle, the area postrema. What, Ajay? What is the role of area postrema?
Sir, it will if it gets affected or infiltrated, it will cause indictable vomiting, sir. Vomiting zone.
Why?
Basically.
Why?
Sir, because there is no blood-brain barrier, sir. There. So
You're right. It also has the chemoreceptor trigger zone there.
Chemoreceptor, sorry, sir. Yes.
CTZ. So every symptom has some anatomical basis, so we should know the anatomy really well. Okay. So good. Thanks for now. We'll join next time. I hope this was useful to you.
Thank you, sir.
Thank you so much, sir.
Thank you, sir.
Thank you, sir.
Yeah. Any suggestion? All is well.
Yes.
Very good, sir.
Okay. Good. Enjoy.
Thank you.
Thank you, sir.
Thank you.